Today, we're going to be discussing building a strong foundation for RHCs in the transition to value. As I said, I am Connie. Here's me. I live in rural, so it's very difficult for me to have really good internet connection when I start my video. So this is me. This is who I am. You'll hear my voice, but you won't see me on video. Today's learning objectives, we were already introduced to them. If there's one thing that I can ask you to take away from today, is to understand that it is not as daunting as a lot of people think it is to move from volume to value. In fact, we're already on our way. We're already doing things that are helping us move from volume to value. With that being said, the main point here is in order to put gas in the tank and get us to actually move up the road to get from volume to value, we need to understand one thing, and that is documentation is the cornerstone of the business. And I know if you've ever heard Tammy talk, this is the one thing that she emphasizes the most. And hopefully throughout today's presentation, I'll be able to explain to you just how we are able to show that documentation is the cornerstone of the business. There is a solid correlation between documentation and reimbursement. And we need to make sure that not only do the payers understand that, not only do we understand that, the coding and billing professionals within our healthcare system, but also our providers understand just how important that documentation is. Because if you cannot properly get the codes from the documentation, you cannot get that reimbursement. And so if there's nothing else you remember today, Tammy will be proud of me. I'm going to say documentation is the cornerstone of business, and have that be the number one thing you take away. So incomplete documentation leads to incomplete coding, leads to incomplete billing, which leads to incomplete reimbursement. And all of these align in a perfect storm to really allow us to be a presence in our rural communities or not. So if you're doing the work, you need to make sure that it's being documented, because by doing that, you're able to get reimbursed for the work that you're actually doing. Now, when we say that it's the cornerstone of the business, this is how we're able to really show and really emphasize not only the work that we're doing in our rural communities, but also the need for the presence. And so when, unfortunately, if and when a rural hospital closes, usually it's due to not being able to financially afford their presence in the community. If there's work that can be done, it's usually in the documentation, because they're able to show that they are doing the work to get that coding, to get that billing, to get that reimbursement. It's usually a business operation and a workflow operation that is in the cornerstone of that documentation. Now we need to focus on components here. And if we think about them as parts of a puzzle or puzzle pieces that are building blocks to our rural health system, let's think about how well we tell the story of services provided as components. The more complete the story, the more accurate the descriptive of each part, and the more successful our billing efforts will be. In turn, that supports long-term viability by ensuring that all the pieces fit together, the entire story of services provided is told completely, and we keep tweaking and improving our documentation and coding until we find that perfect fit. for our individual RHCs. What works for us in our clinic, for our community, and that is success. Now, with coding and documentation, we need to note that our coders and billers have a very important job because they are the ones that are able to translate that story of the actual services that were provided into financial codes. And so in order to identify the correct code, our coders need to know the full descriptions of the code requirement and how it's outlined and what are the qualifiers for each code that is selected. And of course, we got to have our disclaimer. I'm not a biller and coder. I am not here to replace the guidance that's outlined in the CPT manual or official CMS guidance. And so disclaimer is said, we are good to go. The moral of our story and the whole reason that we do what we do is to help our patients, neighbors, and rural communities become and remain more well. Anyone who's ever heard Tammy Norville speak, you know that is her #1 message. Telling our story through documentation to demonstrate the why we do what we do and determining the medical necessity, the complexity, and the intensity is the whole purpose of the coding. We've alluded to the fact that medical necessity is the why we do what we do in the way that we do it. That's the moral of the story, so to speak. Remember, the reason we're chasing high quality and high value is to help our patients and communities to become more well. And the important part on this is the medical necessity. That is the term that relates to whether a procedure or service is considered appropriate in each circumstance. Generally, this is the least radical service or procedure that allows for effective treatment of the patient's complaint or condition. The crux of quality and the heart of providing value-based, patient-centric care is in this decision. The least amount of invasiveness that is going to be able to serve the patient the best. Now here, we must answer these 5 questions to establish medical necessity. The answer is not only establish medical necessity, but also the intensity and the complexity. It's the heart of the story of the services provided, and determining and demonstrating this quote unquote level of care determines reimbursement amount. In a fee-for-service world, it's a bit different for RHCs with the all-inclusive rate for some services, but the process of documentation and coding and billing should be an integral part of the business with ongoing continuing education and quality improvement opportunities. We're moving through a lot of information pretty quickly. If you have any questions, don't forget to either unmute yourself or drop a question in the chat box. I want to make sure that I leave time at the end to be able to answer any questions. Don't hesitate to reach out. My contact information will be on the last slide, and then also Kiona will be able to connect you to NoSOR as well. Let's see here. How do we get to medical necessity? It's built on the clinical documentation. These are the basic components of clinical documentation in a primary care setting, rural or not, fee-for-service or capitated. The first 3 are key components. History is pretty self-explanatory. Physical exam 2. The medical decision-making is the determination of medical necessity. So think of the complexity and the intensity is established here. So just how complicated is this issue, and how much knowledge does the provider need to really rely on? We know that with the documentation requirement, changes that occurred effective January 1 of last year, number 7, time, has a more important role. In the back of your mind, as we're going along, keep asking yourself, how does this change, new requirement, impact the way we do business as an RHC or as a rural primary care provider? As an RHC, do you have payer types other than Medicare or Medicaid? Even if those other payers make up a small portion of your payer mix, these requirements will come into play with them too. We're focused on CMS today, but these rules either already are or will be shortly adopted by all other major payers. It's important to encourage appropriate documentation habits for your providers. And one more note, if providers decide to use time as a basis for coding, it must be blatantly and conspicuously obvious in the documentation. That story still has to be told. Now, if you get paid under an all-inclusive rate, why do you care about the transition to value? Remember, what is the why we do what we do? The why in the story of value, and at the root of value, is medical necessity. We must start with the why we do what we do in the way that we do it, and from there, we can tell the story of services provided. Documentation must be accurate and detailed. The coding must reflect all aspects of the documentation provided. And finally, the billing must reflect all required components and show that they are met and charged appropriately. I want to talk about next steps for a minute. The next steps to the next level of rural primary care. The next steps on our journey to value. Value means different things to different people. And remember, we need to know the why we do what we do in the way that we do it. And it helps define the value for our business. When we talk about value or value-based healthcare, we're really talking about how we provide services, how we treat and perceive the patients we serve. Let's start with a few definitions and other characteristics of value. As with many concepts we deal with daily in healthcare, there are multiple definitions for one concept. And don't forget the acronyms. We do love our acronyms, don't we? Just wanted to provide a little context and a few of the most notable definitions of value-based care. They all have basically the same premise: patient-centric quality services provided leading to improved outcomes and lower costs. As I said, there are several ways to define value-based care, but it all started with the Institute of Medicine's STEEP. We'll get back to that in a second. Then on to the triple aim: better patient outcomes, better patient satisfaction, and lower costs. Right patient, right place, right cost. Now we're on to the quadruple aim, which is the triple aim plus healthcare professional provider well-being. And as I said, with STEEP, we do love our acronyms, don't we? There is a handful of analytical frameworks for quality assessment, and they guide measure development initiatives in the public and private sectors. One of the most influential has been the framework put forth by the Institute of Medicine, which includes the following 6 aims for the healthcare system. Safe, timely, effective, efficient, equitable, and patient-centered. I won't read off the whole slide. You'll have access to these slides after the presentation, so you'll be able to go back, and I have the source there at the bottom of the slide for you as well. Now, the frameworks like the Institute of Medicine domains also make it easier for consumers to grasp the meaning and the relevance of quality measures. Studies have shown that providing consumers with a framework for understanding quality helps them value a broader range of quality indicators. For example, when consumers are given a brief, understandable explanation of safe, effective, and patient-centered care, they view all 3 categories as important. Furthermore, when measures are grouped into user-friendly versions of those 3 Institute of Medicine domains, consumers can see the meaning of the measures more clearly and understand how they relate to their own concerns about their care. Now, you've seen NoSOR's simple definition. It has a more operational perspective of connection to value. When we talk about value, moving towards value, what are we talking about? Why do we need to make sure we're keeping this in mind? Especially if we are just starting down the road from volume to value and developing processes and procedures. It's a very simple definition. Healthcare entities know more than ever that we need to continue the push from quantity-based care to value-based care. For years, the reimbursement structure has continued to prioritize and incentivize the number of services doctors and hospitals deliver instead of the outcomes of the services provided. Success was defined as achieving high profit margins with little to no emphasis on improving quality. This presentation focuses on the difference between volume-based and value-based care, why the transition to value-based care is critical for the sustainability of healthcare delivery systems. And our friends from Stroudwater, well, formerly from Stroudwater, Jonathan Pattenberg, is one of the nation's foremost educators on this, and that was a piece of one of his presentations. Now, the definition we just looked at is simple, very straightforward. The 3 focuses are payment incentives, coordination, and integration of clinical services, focusing on prevention and wellness, as well as information sharing. Again, it is a pretty simple concept, but is it all there? If so, what is the big fuss about? Why is it's such a hard move to transition to value? Is it more complicated than having a patient-centric approach that focuses on improved outcomes for lower costs? And if you get paid under an all-inclusive rate, why do you need to care about this transition to value? Each organization has to answer these questions from their own perspective. And remember, what is the why we do what we do? And what is the why of the story? And at the root of value, what is the medical necessity? Again, at the heart of value is the purpose of the services we provide, the complexity of the services we provide, and the part of the story, if you recall, is told through medical necessity. Every service has a purpose, or don't do it. That's basically the crux of it. Medical necessity, why are we performing the service that we are performing? Is it medically necessary? Is there potentially another option? Is the right thing to do for the patient? Is this justifiable in medical necessity? Just because it's the right thing to do may not necessarily mean it is medically necessary. Which do we do? Answer the why. Or worry about the patient if it is the right thing for the patient. Pardon me. Even if the patient feels it is the right thing for the patient, is it medically necessary? So how do you assess medical necessity, and how does that connect with the value? If the service is not medically necessary, aka justifiable, there is no value. The goal is to help our patients stay more well, not just treating the disease after it presents. We are trying to move toward better, more proactive wellness overall. Now, a quick reminder of the 7 documentation components. This is very important. Clinical documentation improvement. As I said earlier, if it's not documented, it didn't happen. And if the documentation is incomplete, the individuals that code and ultimately bill the services are unable to provide that full story of everything that occurred during that visit and just how much the health professional provided. And just in case we forgot, documentation is the cornerstone of the business. Now, when we measure value, how do we measure it? The healthcare value equation provides a way to understand how well an organization is performing in its journey to value through the use of STEEP and/or the framework of the triple aim or quadruple aim. It is defined as the quality of care made up of outcomes, safety, and service divided by the total cost of patient care over time. As you can see here, it's can be shown as a real equation. Again, we have the definition source on the slide. Here we go with the value is being very much variable. The US health system produces some of the best outcomes in the world, but it also produces some of the worst, as measured by mortality, amendable to healthcare. For example, the top 5 US states would consistently rank the top of developed countries, whereas the bottom 5 would trail behind them. Again, value is variable. Here, the Agency for Healthcare Research and Quality is a hot link for you to go and research yourself the comparison of the 50 states and Washington, DC across all healthcare quality measures. This is a really cool interactive site for you to do some research on. Here are some of the common performance measures to show how you're able to look for quality measures in your own coding billing, even if organizations are not purposely moving toward value right now. These are some of the more low-hanging fruit that organizations can look into that won't completely flip over the boat. It just rocks it a little, helps them open their eyes to moving toward value. Also, here are some payment types that can start them on that road to value. There's a lot of the hospitals are moving towards accountable care organizations or ACOs. Again, we love our acronyms. This is a way that we can help them kind of dip their toe in and move them toward value. Patient-centered medical homes is another way. Chart from CMMI, or Centers for Medicare and Medicare Innovation, they are trying to help move and find different frameworks to be able to have that payment type to move from volume to value. They haven't quite settled on one yet, but they're working on it. They're experimenting at this phase. And how do the RHCs fit in? Now, RHCs currently aren't eligible for the Medicare quality payment programs since they're not paid on the physician fee schedule. However, many of them are participating as part of ACOs because most of them are owned by by critical access hospitals. So they're provider-based rural health clinics or much larger medical groups, which means that they are exempt from MIPS and MACRA. However, they can choose to participate in keeping tabs on those measures, even though they don't have to report them. And it just helps them set themselves up for success. Here in the patient-centered medical home slide, these are some of the things I want to point out about this particular framework. They are able to show that they are improving their quality of care for all of their patients. And no matter the high risk, the low risk, they are changing the way that they provide services overall. This isn't a reactive, like you get sick, you come and see us. This is more proactive to where we keep tabs on you. We help with case management, and it helps lead toward service line integration. Now, there are several definitions of service lines, and depending on the industry and context, I'm going to give you ours for NOSOR. So for our purposes, service lines are provided in a primary care setting in addition to evaluation and management or preventative services, such as chronic care management, principal care management, transitional care management, behavioral health, or even oral health. Here we go, some examples. These are some really, really awesome resources that I would ask you to share with all of your stakeholders. The MLN booklets are published by CMS, and in the slide deck, you'll have access to all of the direct links. But these are really good resources that are basically like Cliff Note versions of a whole program. So, for example, this one here is for chronic care management services. It gives you what the requirements are, what the CPT codes are, and everything. And it really gives you a pretty good omnibus look at the program. With principal care management, it is basically the same as chronic care management. It is just chronic care management requires 2 or more chronic conditions. Principal care management requires 1. But there's some more detail in there with how much time a provider needs to spend with a patient or on a patient's care for that month. But all the details will be in the provided. Here with principal care management, previously, rural health clinics were not allowed to participate in principal care management, but beginning January 1 of 2021, rural health clinics were finally allowed to be able to provide that service to their patients. Something that is really interesting about rural health clinics and just the way that they need to operate and how they're reimbursed is not always do they think that they can provide a service because it's outside of their normal realm. And so there are ways that rural health clinics can provide palliative care and hospice care, but they need to be creative in the way that they do it. And so here's a resource that they can use to be able to provide those services to their patients. Here is an MLN fact sheet on transitional care services. Again, they have a whole library of these fact sheets and booklets. Advanced care planning, which is a hot topic in some states right now. Being able to provide that service of explaining what advanced care planning is and helping them fill out paperwork and understand the decisions that they're making can be a service that our primary care providers can walk our patients through. More handy dandy MLN booklets. And when you get the slides, you'll be able to see all these live links. The most current requirements are going to be in red whenever you see these booklets. They keep them on the same link and they just re-upload. And so these links should be good for you for until they change the way they operate. So hopefully I'm not jinxing myself and you'll be able to access these. Okay, so I'm moving to potential impact of new service line integration. We're switching gears a little bit here. I want to talk about demonstrating value through these service lines. We need to summarize the components of appropriate documentation and coding, describe how documentation and coding are the cornerstone of the business and the foundation of the business. We're going to discuss the paradigm shift, and it truly is a paradigm shift from volume to value, and then detail potential impact of the integration of the new service lines on the business when we're making that transition from volume to value. Now, here's just a spattering, if you will, of current service lines. Some rural health clinics have them, some don't. Some are considering adding. There's pros and cons to each service line. And it truly depends on what their individual communities need. And so the rural health clinic needs to really be in touch with their community and their patients. What are their patients needing? What are they having to send them out for? And is it truly something that they can bring in-house and reduce those ED visits, reduce the need to send your patients out of the community to receive care? Is it within the scope of their provider's license so they're able to operate at the top of their license? We've introduced service lines as a way to demonstrate value, and you're already doing at least, or the providers are already doing at least some of the work, whether they have a process to bill for it or not. For example, a lot of patients like to call up and ask for coordination of care or for information of different community resources. That could be an aspect of chronic care management or in principal care management. And so a lot of the businesses are already doing the work, they're just not getting paid for it. And so by formally integrating some of these service lines, they're able to show that they're doing the work. They're able to document, remember documentation, they're able to document that they are doing the work, and they're able to show that they are transitioning from volume to value. They get credit for it and they get paid for it. And most importantly, their patients are benefiting from the actual forming of the program. Now, there's a few questions to get us started. I would venture to guess that chronic care management is a service line that most RHCs are at least familiar with at this time. If they're dipping the toe into value, this is one of the easier ways to begin their journey. Especially in chronic care management, the rural healthcare providers have really done this work historically, and it's patient-centric, and it's the right thing to do for the patients. A lot of time it is medically necessary, and in rural especially, it is so needed. They are doing the work, they just need to document it so they can get the credit for it. Now, I want to take a moment to thank Kiona and RHPTP, the team at the National Rural Health Resource Center, for the opportunity to spend time with y'all. I hope you found some value in our time together. I look forward to seeing you at our next state session. This was kind of a surprise for everybody, for me to be able to present for you all. I hope I was able to give Tammy some justice. She is currently on Capitol Hill making Hill visits, so I was able to step in and make this presentation for her. I am able to answer some questions, but if they're too complicated for me, I'm going to have to write them down and get back to you. But thank you very much for the opportunity. And do you guys have any questions for me?
If I could, I think I have one question.
Of course.
Okay. I'm used to hearing a lot about accountable care organizations, and within ACO, you hear a lot about the wellness visit. So can you comment on the importance of the wellness visit from the rural health clinic side? It seems like this comes together.
So from my understanding, an annual wellness visit is for Medicare, and it is done once a year for those patients. There is some current changes being made where it needs to be a medically necessary face-to-face encounter with an RHC practitioner to be able to be billed. However, different portions of the visit can be done by other providers.
Yeah.
And so, of course, it's necessary, it needs to be done, but who does it is kind of up in the air right now. They're moving towards being able to allow nurses to do it, like a registered nurse, like higher level nurse. However, it is still up in the air. Right now, an RHC practitioner still needs to provide at least a portion of that visit.
Tony, this is Terry Hill, and first of all, thank you so much for stepping in here. I thought you did a great job, so wanted to say that first of all. The second thing is, I think because of the COVID, I think exactly what you said about the wellness visit applied earlier. I believe that it is now possible to do that virtually. And in fact, I actually have had wellness visits, not necessarily by rural health clinic, but I've had them done virtually. So yeah, unless that changed recently, I think it is possible to do them virtually from a rural health clinic now.
Oh, yes, definitely. So I neglected to mention the 1135 waiver that is currently in place for CMS during the public health emergency. Basically, half of the rules have been thrown out the window at this time. So it's not a total free-for-all. The standards are still there, and it needs to be what's best for the patient. But a lot of the regulations have been relaxed. The important part of that is to know that as soon as the public health emergency is over, everything turns back into a pumpkin. And so if you are, as long as you have that in mind, you can go ahead and be operating with those relaxed regulations. But I apologize, I didn't specify that I was speaking of regular times, non-world pandemic times. Thank you for pointing that out.
As always, we encourage you to reach out to Rich with any TA questions that you may have. And thank you again for your participation. We hope to see you in session number 2. Thank you.
Thank you all.